Okay, welcome everyone. It's Dr. Linda here. In this video, we're going to be talking about the lower extremity, everything from the pelvic girdle down to the feet. So when we look at the pelvic girdle, this is a pretty simple overview of just some of the main bones that make up the pelvic girdle. And this bone and this bone they call innominate bones. And innominate is really this entire section is called an innominate. And innominate means no name. It's an odd name for something and give it no name called the innominate. But each innominate is made up of three bones that ankylose. And when we say that word ankylose, it means they fuse. We have the ilium, the ischium, and the pubic bone. Those three bones ankylose and fuse, okay? In addition, we have this on top called the iliac crest. We have this deep depression on both sides, which is where the head of the femur will articulate, and that's called the acetabulum, also known as the acetabular fossa. Then we have the pubic symphysis. Now the pubic symphysis doesn't look like it's labeled properly. That this line should really be going here in the center. Okay, so this pubic symphysis, we should correct it and put a dot, let's say right there in the center. That's the cartilage, that fibrocartilage that runs perpendicular. Okay, and then we do have the pubic arch down here and down here. When we look on the model of the bone and we rotate the innominate bone to the side, this right here, this bone on the left-hand side, this is going to be the right innominate bone. This is the right one. So, and the reason why I know that is, I'll give you some landmarks here. On top is the iliac crest. And again, we're looking at this from the lateral view, from the side view. This is the acetabulum. So this is where the head of the femur is going to articulate. So that can't be on the inside. That has to be on the outside. So if this is on the outside, now this portion here, I'll put a dot there and a dot here. This is called the ASIS, the anterior superior iliac spine. I call it ASIS. If you're ever asked that on an exam, you cannot abbreviate. You have to write out anterior superior iliac spine. And then just inferior to it, there's another prominent bony landmark called the anterior inferior iliac spine, or the AIS. So there's an anterior superior iliac spine, and then below it, an anterior inferior iliac spine. Now, if we go back to the iliac crest and we go backwards or posterior, we're going to get to two other bumps, 1, 2, and they would be analogous to what we just saw in the front. There is a posterior superior iliac spine, and then just below it, a posterior inferior iliac spine. Okay. Now, just below that, there is this large notch, and then there's a small notch. This large notch, and we also see it on the right-hand side, we see it here, and then here. This large notch is called the greater sciatic notch, and this little small one is called the lesser sciatic notch. So you have a greater and lesser sciatic notch. Let me get my pen and just erase that again so we could see it a little bit clearer. So on the posterior side, there is this greater sciatic notch and a lesser sciatic notch. And right between, there's a structure called the ischial spine. The ischial spine. So the ischial spine is a landmark that separates the greater from the lesser sciatic notch. Now, that's the key landmark to know the difference between anterior and posterior, is the greater and lesser sciatic notches. Okay, so we know the sciatic nerve is on the back of your thigh, right? When people get sciatica, they don't get pain in the front of their thigh, they get pain on the back. So understand that concept, that when we're looking at the pelvic bone or the innominate bone from the side, how do we determine anterior from posterior to start naming anterior superior iliac spine and posterior superior iliac spine? That landmark is just look for the greater and lesser sciatic notches. That will be the posterior side. And that's how we know that's the posterior superior iliac spine and the posterior inferior iliac spine. Much like when looking at the scapula, how do you know the difference between the anterior and posterior? You have to find the spine of the scapula. All right, when we're looking at the innominate bone, look for the greater and lesser sciatic notches. Okay, so this is the outside portion. That's the outer portion. And then on the right, that's going to be the inner portion. And on the inner portion, there's a smooth depression called the iliac fossa. Okay, the iliac fossa is an important landmark because when we get into muscles, there's a muscle that's called the iliacus. The iliacus. And the iliacus is a primary hip flexor that originates on the iliac fossa. Okay. When we look at it from the posterior, so let me just erase my pen. We're looking at the pelvic bones from the posterior side. And here is the iliac crest. And when you follow it right to the end, this portion right here and this portion right here, that's going to be the posterior superior iliac spine. And then when we go down here and here, those are going to be the posterior inferior iliac spine. Okay, and from the posterior, which we're looking at now, we can also see that greater sciatic notch and a little bit of the lesser sciatic notch, and then that little bump right there is the ischial spine. The ischial spine. We could see the same thing right there. There's the ischial spine. Between the innominate bone and the sacrum, right, where they articulate, those are called the SI joints or sacroiliac joint. The SI is there and there, sacroiliac joint. Here's your L5 vertebrae. Here's your iliac crest. Don't confuse the ischial spine with the ischial tuberosity. This is the ischial spine that separates the greater sciatic notch from the lesser sciatic notch. That's the ischial spine. The ischial tuberosity is a very important landmark, extremely important, because when we do muscles, we will learn of muscles called the hamstring muscles. And the hamstring muscles attach to the ischial tuberosity. And this is actually the part of the pelvic bone that makes contact with the chair that you're sitting on. They call it the sit bone. This is the sit bone. This is what makes contact with the chair. This is the acetabulum. And then the obturator foramen is this hole right here. Obturator foramen. It is the largest hole or foramen of the human body. Okay, from the front, here, this is the SI joint. And then here, the SI joint. It's where the sacrum and the ilium come together. This is the ilium. This is the iliac crest. Anterior, superior iliac spine. Anterior, inferior iliac spine. Why are they important? Because the ASIS is an attachment site for the sartorius muscle, longest muscle in the body, originates right there. And then the AIIS is the attachment site for the rectus femoris, which is one of your quadricep muscles. Rectus femoris. And you're going, oh God, do we have to know this, right? So if you're thinking it, it's yes, you do have to know it, because this information that I'm introducing to you is going to come to haunt you for the next exam. When I point on an exam and I go, what muscle originates here, or what muscle originates here, you can't forget the bony landmarks. You have to now connect the dots, right? We're building on the information that we're teaching you. It's just not, here's information, great, you took the test, pass it, purge it, delete the file, forget it. It's not quite like that. You have to hold on to it and then go, oh, that's why he taught us the ASIS and the AIIS. Oh, I get it. That's why he taught us the iliac fossa, because the iliacus originates there. Okay, so please make sure you understand why I'm teaching you these landmarks. There's major significance. It's going to come in handy when we cover muscles. When we do muscles, it's not just naming muscles, but it's knowing what the muscles do, what their actions are, where they originate, meaning what bone do they originate, and where do they insert, meaning what bone do they attach to. Okay. Here's the pubic symphysis. That's the fibrocartilage that runs vertically. And then here is the pubic arch, here and here. Okay, let's look at the femur, longest bone in the body. And when we look at the femur, on the left-hand side, we're looking at it from the anterior, and on the right-hand side is the posterior. And the major landmark on the back is the linear aspera. The linear aspera is this line that we see on the back of the femur. The front is nice and smooth. It's contoured smoothly, the shaft. But on the posterior side, there is this ridge or this line called the linear aspera. That's how you know you're looking at it from the back. Okay. At the top portion, we have the femoral head. We have the femoral neck. And remember when we did the humerus, there was a greater and lesser tubercle? Well, in the femur, there's a greater and lesser trochanter. The larger one, which is lateral, is the greater trochanter, and the one that's more medial is the lesser trochanter. Again, we have a greater trochanter. We'll put a G for greater, and then the one more medially, we'll put an L for lesser. Don't confuse lesser tubercle with lesser trochanter. The greater and lesser tubercles are of the humerus, of the arm, and the greater and lesser trochanters are on the longest bone in the body, called a femur. Okay, when we move distally, right, we move down the shaft, and we have a medial epicondyle, and we have a lateral epicondyle. And then lower to that, we have a medial condyle and a lateral condyle. Remember, epi just means above. So you have a lateral condyle, a medial condyle, and above them, we have a medial and lateral epicondyle. This surface on the anterior, right here, this smooth surface, is where the patella, which is the kneecap, is a sesamoid bone. It is the patellar surface. This is where the patella or the kneecap is going to articulate with. On the posterior side, there's a depression back here, and that's just called the popliteal surface. On the back, behind the knee, you're going to have the popliteal artery and the popliteal vein and the popliteal nerve, all palpable behind the knee on the posterior side. Okay. When people have, let's say, a hip replacement, a typical hip replacement, they will cut off everything from here up. And then they put in a metallic implant to replace this. A less, I don't want to say less invasive, but there's a newer procedure that's done in the city at the hospital for special surgery. I know it, and I know it well because I had it myself. If you're younger and more athletic, you want to keep as much bone as you can. So what they do is they take a portion of the femoral head, this portion here, and they chisel it off. And then what they do is they put an implant to match it with a screw that goes right in here. And you save all of this bone. They call it a hip resurfacing. This is like chromium and nickel. Okay, it's still metal. And then they put in a new female part in the acetabulum to match it. So the female portion, which is the acetabular fossa, that is a metallic implant. And then this portion of the head of the femur is also metallic. So this is a lot less metal than cutting all of this off and then inserting this metal shaft deep into the medulla and making all of this metal. Okay. So just an alternative treatment in case you're getting into healthcare or you have family members that are debating getting a hip transplant or a hip resurfacing. I had a hip resurfacing, I think it was over 2.5 years ago. Best thing I ever did. I bike every day, I run, I squat, I do all those things. It has not impaired my function. So great procedure. Here's the kneecap. So this is the patella. And the patella has a wide base, and then it has the pointy apex, right? When you think of a mountain, most people think of it like this way. The base is on the bottom, and then the apex at the top. When you look at the patella, the base is on the top, and the apex is on the bottom. That's your kneecap. This is the bone where your quadricep muscles are going to insert. Your powerful leg extensors are going to attach there. When we look at the leg, now we have to look at the medial tibia This is the tibia. And then we look at the lateral fibula. Of the two bones, the fibula is smaller. And just remember, you tell a small fib. So if you tell a small fib, the fibula is the smaller of the two bones. The fibula is also the lateral bone, and the tibia is the medial leg bone. When we look at the top of the tibia, we have a lateral tibial condyle, and then we have a medial tibial condyle. If we move down just a little bit, there's a bump that all of us have just below the kneecap on the tibia, and it's called the tibial tuberosity. This is where your quadricep muscles insert. This is where your quads insert. They attach right there. They go over. Your quads are the large muscles in front of your femur. They attach and go over the patella. It goes over the patella, and then their final insertion site is going to be right there on the tibial tuberosity. Now, if you're 13, 14, and 15 years old and you're playing lots of soccer, lots of ice hockey, there's a condition where this becomes very enlarged, very prominent. It sticks out a little bit more and very tender. And when it does, it's only because they call it Osgood-Schlatter's disease. And it sounds very, very serious, but it really isn't. They call it Osgood, O-S-G-O-O-D. They call it Osgood-Schlatter's disease. And all it is like an avulsion of the tibial tuberosity. Since the quadriceps attach here, every time you kick or extend or push off with your large leg muscles, your thigh muscles, the quads are pulling, they're pulling on the tibial tuberosity, and that bump becomes more prominent and very tender, especially during the growing years. And I've treated many, many young people with Osgood-Schlatter's over my 26 years in practice. And some of the most productive treatments isn't just ice, but I'm going to say cold laser therapy. When I use cold laser in about 3-4 minutes of time, it really cools this off and brings about an immense degree of pain relief without pain medications and getting ulcers. It's called cold laser therapy. Very, very helpful. Now, in the same line as the tibial tuberosity, if we go horizontally in this direction, in that same horizontal plane, now we get to a structure that's called the head of the fibula, or the fibular head. So this is the fibular head, and it's in the same horizontal plane as the tibial tuberosity. They're perfectly in the same horizontal plane. When we follow the fibula distally all the way down at the bottom, it takes us to the lateral malleolus. And when we follow the tibia distally, it takes us to the medial malleolus. This is the lateral malleolus. This is the medial malleolus. So here's the head of the fibula, or fibular head. Same horizontal plane as the tibial tuberosity. Here's the shaft of the fibula. We follow it down to the bottom, and there's the lateral malleolus. On the top, where the tibia and fibula articulate, you'll see on the bottom, the tibia and fibula articulate again. So since one is more superior, we just call it the superior tibiofibular joint, and down below is the inferior tibiofibular joint. It's just where they attach. Okay, let's look at the foot. Here is a bird's eye view looking down. This is the right foot. again, superior view. We have tarsal bones, and remember in the hand we had carpals. There were 8 carpals. In the foot, there are 7 tarsals. Then we have 5 metatarsals, and then we have 14 phalanges. So let's start with the metatarsals first, because they are the easiest. We start at the great toe. This is the first metatarsal, second, third, fourth, and fifth metatarsal, always by Roman numeral. Okay, then we go distal to that, and then we have a proximal, a middle, and a distal phalange of toes 2, 3, 4, and 5, much like the hand. The hand, also digits 2, 3, 4, and 5, also have a proximal, a middle, and distal phalange. The only one that's different is the great toe. Much like the thumb of the hand, there's only a proximal and a distal phalange. There is no middle phalange of the great toe. There's only a proximal and a distal. There is no middle phalange. Okay, now let's look at the 7 tarsal bones. Articulating with the first, second, and third metatarsal, there is a first, second, and third cuneiform, and their other names are medial, lateral, and intermediate cuneiform. So there's a first, second, and third cuneiform, which articulates with their corresponding metatarsal. And we also call it the medial cuneiform. Number 3 would be the lateral cuneiform, and the one between the both would be the intermediate cuneiform. And then all the way or I should say lateral to the lateral cuneiform is the cuboid. So this entire row all start with C's. Cuneiform 1, cuneiform 2, cuneiform 3, cuboid, right? Or in medial, intermediate, lateral cuneiform, cuboid. They're all C's. Okay. Posterior to the 3 cuneiforms is a navicular. That's the navicular bone. Superior bone is called the talus. And this talus is going to articulate right here. This is where the talus is going to articulate to make the ankle joint. So your foot can bend or dorsiflex and plantar flex. It's going to articulate with the tibia and the fibula where the medial lateral malleolus are. They are going to clasp here and here. This is going to be the medial malleolus, and this on this side will be the lateral malleolus. Okay, and then the heel is the calcaneal bone. The heel is the calcaneus. Let's look at it from the lateral view. This is the right, this is the right foot. So on the posterior side and inferior, we can see the calcaneus. The talus sits right on top of it. It's the superior bone. So that's the talus. Anterior to that is the navicular. And now if we're going lateral to medial, right, since we're looking at the outer foot, this is the cuboid. This is the third cuneiform. This is the second cuneiform, and you can't see the first. Why? Because it's too far medial. it's on the inside. You got to look at it from the opposite side, but one would be only viewable from the medial side. Then we have the, let's do this properly. Then we have the fifth, fourth, third, second, and first metatarsal. Then we have a proximal, middle, distal phalange. Proximal, middle, distal phalange. Proximal, middle, distal phalange. What about the great toe? The hallux only has a proximal and a distal. There is no middle phalanx. From the medial view, now we can see the heel bone, which is the calcaneus. A lot of runners get these heel spurs. They get these bony growths right here called calcaneal heel spurs. And what I do is I make these orthotics for patients with customized orthotics that have a specific depression that's built in so that this spur hits this nice depression. So every time they have heel strike of the gait cycle, the spur doesn't hit a hard surface. The most superior bone is the talus. That's the talus. Anterior to the talus is the navicular. And now we can see cuneiform number 1, also known as the medial cuneiform. Here's our first metatarsal, then our proximal and distal phalange of the hallux. Hallux is the great toe. Okay.